management of menstrual disorders. You should go beyond management of acne and hirsutism. You should go beyond management of infertility. Otherwise, you will be doing a disservice to these patients. Because more important, many times than these symptoms that we manage in the clinic are the long-term complications of polycystic ovary syndrome. And that's the reason why diagnosis of PCOS should not be taken lightly at all, because to some extent, diagnosis of polycystic ovary syndrome is a light sentence. Okay. So today we will not talk about ovulation induction, we will not talk about management of androgen excess, we will not talk about menstrual disorders, we will talk about the metabolic and cardiovascular impacts of polycystic ovary syndrome and how do we manage this. Okay. I'd like first of all to review with you diagnostic criteria for polycystic ovary syndrome. I'm sure you're very tired of this topic, but let me just point out a few things. We have actually 3 criteria for diagnosis. One is the classic National Institute of Health criteria 1990. This is an American criteria. The other one is Rotterdam, which was the result of a consensus conference between the Americans and the Europeans. I don't know whether there were Asians in the group. And then, of course, we have also the criteria from the Androgen Excess Society. Yes, Virginia, there is an Androgen Excess Society. And they came out with their own criteria in 2006. Now, with the classic NIH criteria, you need to have oligomenorrhea and you need to have hyperandrogenism. And polycystic ovary syndrome is not necessarily a requirement. And the reason is because at that time, the Americans who were treating polycystic ovary syndrome were the endocrinologists, not the gynecologists. And the American endocrinologists were not doing ultrasound. Now, with the Rotterdam criteria, you may or may not have, that's plus or minus, oligomenorrhea. You may or may not have hyperandrogenism, or you may or may not have polycystic ovary syndrome, because the requirement is any 2 of the above criteria, while in the NIH criteria you need both oligomenorrhea and hyperandrogenism. The Androgen Excess Society is a little more emphatic. You may or may not have oligomenorrhea, you may or may not have polycystic ovary syndrome, but polycystic ovary syndrome is a androgen excess disorder. So you must have hyperandrogenism. Now, what happens because of this? What happens because of this is you create many phenotypes of polycystic ovary syndrome. You may have polycystic ovary syndrome without oligomenorrhea. You may have polycystic ovary syndrome without hyperandrogenism. You may have polycystic ovary syndrome without polycystic ovaries, because of the criteria as promulgated by Rotterdam. Right. So when we talk about complications long-term in terms of metabolic and cardiovascular events, we are referring to classic PCOS, because classic PCOS, those with menstrual irregularity, hyperandrogenism, with or without polycystic ovary syndrome, as enunciated by the NIH criteria, is the one that is associated with long-term complications. Because if you follow Rotterdam, or you will come up with phenotypes that may not have hyperandrogenism, that may not have oligoovulation. There will be milder forms of polycystic ovary syndrome, and you may have even non-hyperandrogenic PCOS, which actually is almost a normal woman. So we're not referring to those women, we're referring to the classic polycystic ovary syndrome. For which reason, therefore, I have a simple outline. I'd just like to review very, very briefly the pathophysiology of PCOS as it relates to complications over the long term, and then give you, in contrast to my earlier lecture, which is not evidence-based, give you now more evidence-based discussion on the metabolic and cardiovascular impacts of polycystic ovary syndrome to emphasize to you the fact that we have evidence that polycystic ovary syndrome is a disease for the generalist. Not only for us, it's a disease that complicates the woman's life for the rest of her life. And then whatever we can do to minimize and prevent these complications. I have just one diagram here. I'm not going to bore you with other diagrams. And this is just to give you what we call a unifying hypothesis. Because many of the problems that will result in cardiovascular disease later on may be related to obesity, insulin resistance, and so on and so forth. And this is just to demonstrate to you the fact that here we have hyperinsulinism. Of course, this is compensatory because the primary problem is insulin resistance, increased peripheral insulin resistance. Not the central peripheral insulin resistance, but the peripheral involving target cells like muscle tissue. And because of increased insulin resistance, we have a compensatory hyperinsulinism or insulinemia. It is not insulin resistance that is bad, it is actually the hyperinsulinemia, because this is the one that stimulates both adrenals and ovary. Please remember LH. LH stimulates the Pcos cells of the ovary to stimulate the ovary to produce androgens from cholesterol. Now, think of insulin as a cogonadotropin. It acts like LH. So that insulin increases the secretion of androgens from both ovary and adrenals. And you have a state of hyperandrogenism. This affects fat cells, especially in the viscera. We know that visceral obesity is the one related to cardiovascular disease. And as a result of this, you have a decrease in adiponectin and an increase in other cytokines, including tumor necrosis factor alpha, interleukin-6, leptin, other factors. And this conglomeration of cytokines, some increase, some decrease, actually has a direct effect on the adrenals and ovary, promoting more secretion of androgens. It also has an effect on the target cells, muscle cells for example, creating problems with carbohydrate metabolism, insulin resistance, and more hyperinsulinemia. So you have what is known as a vicious cycle. And the moment you have polycystic ovary syndrome, you will have all these segments of the equation, and you have a never-ending process of hyperinsulinism, hyperandrogenism, predisposition to metabolic and cardiovascular complications. And that's the reason why we say that polycystic ovary syndrome is a lifetime disease. And you know very well that there are reproductive as well as metabolic complications. We're not going to discuss reproductive complications. You're all familiar with this, menstrual problem, hirsutism, acne, infertility. We concentrate on metabolic complications. We now realize that polycystic ovary syndrome starts with in utero, right? Extends throughout the life of a woman. And you can have obesity, metabolic syndrome, glucose intolerance, type 2 diabetes. Now we include here non-alcoholic fatty liver disease, which we generally do not associate with PCOS. And of course, dyslipidemia and consequently cardiovascular disease. One thing that we have not really recognized is the relationship between polycystic ovary syndrome and depression, and the relationship between depression and ultimately cardiovascular disease. Of course, we're familiar with endometrial cancer. So respecting the metabolic and psychological complications, you can see how serious polycystic ovary syndrome is. Okay. So what follows now are just a review of the literature, just to prove to you that this contention is correct. We talk about visceral obesity, metabolic syndrome, non-alcoholic fatty liver disease, diabetes mellitus, cardiovascular disease, and depression. Right. Okay. We did a literature survey some time ago, and we wanted to find out what is the prevalence of obesity among women who have polycystic ovary syndrome in selected countries. Unfortunately, we don't have data from the Philippines, so I'm sorry about that. But we have data from Hong Kong, China, and Thailand, as opposed to Europe, as represented by Italy, and Spain, and the United States. And surprisingly, Spain has just about 20% of the women with polycystic ovary syndrome are obese. But for the Southeast Asian countries, about 50% of PCOS are obese. Of course, the Italians are lower. I don't know whether it is together with Spain, the result of the Mediterranean diet, but certainly the Americans, because maybe of McDonald's, and KFC, and now Jollibee, has 70% of their polycystic ovary syndrome patients as having obesity. And please remember, the definition of obesity is different from Western compared to Asian countries, because International Diabetes Federation believes that we should use a lower BMI, right? And then what is significant is that this kind of obesity is actually central rather than a peripheral type of obesity. And here is a study of 110 patients with polycystic ovary syndrome against weight match controls. This is obese women, whether you have PCOS or not, you're obese. Because of obesity, obesity is a cause of insulin resistance, whether you are polycystic or not, and it could increase central fat, right? But what is important here is you look at overweight women, and more particularly among normal weight women, whether they have PCOS or not. And you can see that even if the normal woman with polycystic ovary syndrome is of normal weight, she has a significantly higher amount of central abdominal fat compared to a non-PCOS woman. So you don't have to be a fat PCOS to have extra visceral fat. You just have to be PCOS, right? And if you look at serum insulin level, of course, it will be higher among those PCOS women because of increased abdominal fat, whether you are normal weight or not. And the reverse of insulin resistance, of course, is insulin sensitivity, which is reduced significantly among women who have polycystic ovary syndrome but of normal weight. And again, if you are overweight, and this is the worst situation, you have polycystic ovary syndrome, you are overweight, you have increased abdominal fat, then you have much higher levels of serum insulin and lower insulin sensitivity, meaning therefore higher insulin resistance. Okay. Now, what about metabolic syndrome? Of course, following obesity, you go to metabolic syndrome. And again, we looked at some reports from neighboring countries as well as from Asia and mainly from United States and Europe. And again, the incidence of metabolic syndrome varies from country to country, but for Southeast Asian countries, I would say about 25–30% of patients with polycystic ovary syndrome have metabolic syndrome. And you know what metabolic syndrome means in terms of cardiovascular disease and diabetes mellitus. And again, the United States leads the world in terms of women with polycystic ovary syndrome and metabolic syndrome. Okay. And this is what happens if you have metabolic syndrome because of this pathogenetic mechanisms involving atherogenesis, dyslipidemia, etc. You have 2 times the risk for cardiovascular disease, you have 5 times the risk of type 2 diabetes, and if you have type 2 diabetes, you have 3 times the risk of cardiovascular disease. All drugs lead to cardiovascular disease. Now, one complication that is seldom mentioned with regards to polycystic ovary syndrome is non-alcoholic fatty liver disease. And if we look again at the literature, we did a study of the literature that are available. You can see that the range of NAFLD among women who have polycystic ovary syndrome varies from country to country. But overall, all the studies therein shows about 50% incidence of non-alcoholic fatty liver disease among women with polycystic ovary syndrome. And why should you be afraid of this? Because Non-alcoholic fatty liver disease can lead to non-alcoholic steatohepatitis, cirrhosis, and to hepatocellular carcinoma. Not too many, but still a significant number. So this is one of the complications of being polycystic ovary syndrome. By the way, you can't blame anybody except yourself if you have polycystic ovary syndrome because you did not choose your parents. It's something that you inherited from diabetic parents. Okay? Now, what about glucose intolerance and diabetes? Here's a study showing you the incidence of impaired glucose tolerance and diabetes among women with polycystic ovary syndrome compared to other polycystic ovary syndrome but non-obese. So all polycystic ovary syndrome, right? Non-obese PCOS, you can see significant increases in impaired glucose tolerance as well as the diabetes. Definite proof that PCOS associated with diabetes. This is a study of white and African American women aged 20 to 32 years. And I'd like to emphasize this age, 20 to 30, they're young women, younger than you, or just about the same age as you, right? With polycystic ovary syndrome, they were followed for about 18 years, and you can see comparing polycystic ovary syndrome women with controls, you have significantly higher risk of diabetes and dyslipidemia and hypertension. These are young women. You can see right from the very beginning that they already have the seedings for cardiovascular disease. Now, let's talk about adverse cardiovascular disease and metabolic profile. And the reason why I'd like to do this now is because there is an impression that the surrogate markers for cardiovascular disease is increased with polycystic ovary syndrome, but is there an increase in the incidence actually of cardiovascular disease? In the latest guidelines of the Philippine Society for Reproductive Endocrinology and Infertility, which was published during the term of Eileen, there is a statement there that even if the surrogate markers are increased, there is no evidence that cardiovascular disease is increased. That was what we believed about 2 years ago. Now, probably we know a little better. Because if you look at those studies on the incidence of cardiovascular disease in women with polycystic ovary syndrome, they are less than robust studies, and therefore may not be reflecting the two stable phase. Let's look at some of the studies. This is a study of over 11,000 women, polycystic ovary syndrome, right? And these are compared to whites, blacks, and Hispanics. And you can see the incidence of obesity, the risk, not the risk, not the incidence. The odds ratio for obesity is increased by 400 times, diabetes 250 times, hypertension 1.41%, and dyslipidemia is 53%. So these are adverse cardiovascular risks and metabolic risks for women with polycystic ovary syndrome. This is a study of 24 obese polycystic ovary syndrome patients, and here we look at coronary artery calcium, which is an indicator of cardiovascular disease, an endothelial marker, which you can measure by ultrasound. The incidence of coronary artery calcification among obese PCOS compared to controls is significantly increased. 5.5 is the odds ratio. That indicates a 550% increase. And that's significant because 95% confidence interval is between 1.03 to 29, though the interval is quite wide, it remains significant. So significant incidence of coronary artery calcification among women with polycystic ovary syndrome is a marker for early coronary atherosclerosis. And a much more telling statistics is from the WISE study. WISE stands for Women's Ischemia Syndrome Evaluation, and here we have measurements for angiographic coronary heart disease, as well as for the cumulative 5-year cardiovascular event-free survival. And for women with polycystic ovary syndrome compared to those women without polycystic ovary syndrome, you have a significantly increased risk for angiographically shown coronary heart disease and a significantly less cumulative 5-year cardiovascular event-free survival. Telling evidence is that there is really some significant effect of polycystic ovary syndrome on cardiovascular disease. And there is also evidence that this effect may extend beyond the menopause. It doesn't stop when you stop menstruating. And here's a study. This is the Rancho Bernardo study, surprisingly. 713 postmenopausal women. Look at the mean age, 74 years, right? Mean body mass index not too high, it's 24. This is just about okay for Western women. But comparing the effect of age against the effect of polycystic ovary syndrome on cardiovascular disease, here the relative risk is increased by just 6%, while in women with polycystic ovary syndrome, regardless of the age, the increase is 36%. The same thing with coronary artery disease. So the mere fact that you have polycystic ovary syndrome means that you can have your coronary artery disease for the rest of your life. Now, what about depression? Is there evidence that PCOS is associated with depression? Answer is yes. And this appears to be independent of whether you are obese or not. All PCOS patients here, the odds ratio is 4.03, and this doesn't seem to be affected by the body mass index. So regardless of your body weight, you are depressed if you have polycystic ovary syndrome. Right. And there is definitely a relationship between depression and coronary artery disease. This is a meta-analysis of 45 observational studies, but nevertheless 6,300 cardiovascular events. And you can see that regardless of what type of studies were done, whether these are etiological or prognostic studies, there are significantly higher incidence or odds ratio or relative risks for depression in women with polycystic ovary syndrome. It's unadjusted, adjusted, semi-adjusted, the increase is as much as 0.8, ranges from 81% to 200%. And this is my last, not slide, this is my last graph, just to show to you that all roads lead to cardiovascular disease. Obesity, insulin resistance, androgens, metabolic syndrome, hypertension, dyslipidemia, type 2 diabetes, cardiovascular disease. And maybe to this diagram, we should add now depression as one of the roads towards cardiovascular disease in women with polycystic ovary syndrome. So having said this, having proven that polycystic ovary syndrome can lead to metabolic and cardiovascular complications, what can we do, right? Well, at the moment, this is all that we can do. This is a position statement by the Androgen Excess Society, and suggests that all women with polycystic ovary syndrome should be assessed with BMI, waist circumference, serum lipid glucose, blood pressure. So this is now your responsibility as a gynecologist, whether you want, if you want to treat patients with polycystic ovary syndrome, all women with PCOS should be assessed for the BMI, waist circumference, serum lipid glucose, and blood pressure. And those women with risk factors, you may refer them to your friendly internist, or you may want to do yourself this different tests, oral glucose tolerance test, if with obesity, advanced age, gestational diabetes, or a family history of diabetes. What can we do in terms of prevention? Lifestyle modification, weight loss, diet, physical activity, and maybe pharmacological intervention in the form of insulin sensitizers, anti-obesity drugs, statins, and oral contraceptives. I have a few more slides. And what I'm going to do now is, what's the current state of affairs regarding lifestyle modification? Does it really prevent this complications? And what about insulin sensitizers, metformin, for example? What about anti-obesity drugs, Orlistat, for example? What about statins? And what about OCs? Because OCs are very, very commonly used for women with polycystic ovary syndrome. Most of the time to regulate menstruation, many times to treat acne and hirsutism, but does it have any long-term effect in terms of metabolic and cardiovascular complications? We'll see, right? So this is just a summary of some of the recent literature. Let's look at nutritional management. A standby, the mainstay in the management of any obese condition, and it's suggested that you should restrict your fat intake to less than 30% of your total calories. Okay, so starting this afternoon, do this. Now, avoid high intake of high glycemic index carbohydrate. High glycemic index carbohydrate makes you that you metabolize very fast. You eat this at 8 o'clock, you are hungry by 10 o'clock. Eat something that will stay in your stomach longer, and then you can last until 12 o'clock for your next meal. Distribute your calorie intake between several meals a day. Do not miss your meal. Take it regularly but small. And if necessary, use drugs to improve insulin sensitivity. And use of anti-obesity drugs, for example, can be justified as a short-term jump-start measure. Okay, what about exercise? Everybody says exercise, but how do you prescribe exercise? Now, we don't have time for that, but this is a review of literature on the relationship between exercise and polycystic ovary syndrome. And there is a conclusion from all of these studies that exercise alone or with energy restriction, that means exercise alone or exercise plus diet, actually improves fitness, cardiovascular, hormonal, reproductive, and psychological outcomes, and likely to have long-term implications. But look at the rejoinder. We need research with rigorous study designs. So far, the studies may not be as robust as we would like them to be. We pay homage to exercise as a natural form of preventing these complications, but we really have not done the necessary or requisite studies. Now, there is evidence, however, that lifestyle management will improve depression and quality of life in women with polycystic ovary syndrome, even if they are obese. And you can see here the effect of diet only, and diet plus aerobic exercise, and diet plus aerobic and resistance exercises. And this is using the Center for Epidemiologic Studies Depression Scale. This is CESD. And you can see that by week 10, whether you are on diet, whether you are on exercise plus diet and exercise plus diet with aerobic resistance, you have a significant improvement, meaning a decrease in depression scores by week 10, although by week 20 this went up a little. So there is evidence that depression can be improved by lifestyle modification in women with polycystic ovary syndrome. What about metformin? What about insulin sensitizers? All right. This is a review. This is the latest I can get, 2007. I'd just like you to look up statements number 4 and 5. Metformin reduces insulin resistance, right? Of course, it improves ovarian functions, regulate cycles, and potentially, alright, so but as far as we're concerned, we know that it reduces insulin resistance and likely to delay diabetes onset and as a role in PCOS. Likely, that means we're not really very sure. Probably we still need the studies, right? Now, this is a much later review of insulin sensitizers. As far as obesity is concerned, we have 14 randomized controlled trials. All of them dealing with, almost all of them anyway, except 2 patient studies dealing with polycystic ovary syndrome. And the conclusions are as follows. This is insulin sensitizers and obesity. Decreases body mass index versus placebo. And the weighted mean difference is -0.68, and this appears to be significant. But you may have to use a higher dose, which means that you may have to use more than 1500 milligrams per day and you have to wait for at least 8 weeks before you can see an effect. So can we or we not use metformin to reduce weight? I'm not sure what the answer will be. Now, what about anti-obesity drugs? The only one available now is orlistat. No other drug for reducing weight is available because this is the only one that has remained approved. And this is a small, very, very small study, just 10 obese patients, but this gives you an insight into how orlistat works. And there is evidence that orlistat reduces visceral adipose tissue. We're concerned with visceral fat, of course. And here you can see from initial visit to last visit, this is a total of 20 weeks, you have a significant decrease in mean body weight, significant decrease in mean body mass index, a significant change in mean waist circumference, and then a significant decrease, about 15%, in mean total abdominal adipose tissue, not much with subcutaneous tissue, and mean decrease in visceral adipose tissue. So this is not an advertisement for orlistat, but this is evidence that orlistat may reduce not only your total body fat, but also your visceral fat. And there is some preliminary evidence that orlistat may also reduce some of the parameters or surrogate markers for non-alcoholic fatty liver disease. What about statins? Very commonly used for women, as well as men, of course, for the prevention of cardiovascular disease. Does it have any role in polycystic ovary syndrome? The answer may be. The use of statins, with or without the use of oral contraceptives, did not improve menstrual, but this HDL cholesterol did not improve high sensitivity C-reactive protein, did not improve fasting insulin, did not improve insulin resistance. Of course, it reduced testosterone, total T, LDL cholesterol, and triglycerides. So what is the problem here? The problem here is in the wrong choice of oral contraceptive. And I'll show this to you. This is a study, very small one, just about 48 future women. This is from the University of Pisa. It's a very interesting study because they used here, yes, testosterone containing OC, 20 micrograms of ethilestradiol alone or with metformin compared to same yes plus ciprofloxacin acetate. Ciprofloxacin acetate is the progestin for the young. But it's also available as ciprofloxacin acetate alone, as progestin, as an anti-vegetation agent. So here they have two groups, three groups, testosterone with 20, that's yes, yes plus metformin, yes with CPA. And I'm going to bore you with these slides, but let me just look at some of this. This is total cholesterol. And you can see it is significantly increased with CPA. But isn't changed with yes and with yes plus metformin. Right. And the same thing is shown in some other of these parameters. This is weight, for example, and it is reduced with yes. It is not reduced with yes plus metformin, right? And it is increased actually with CPA. And this is my last or two slides. These are changes in index of glucose tolerance, and again showing you not very good effects of CPA containing OCs, but better effect of testosterone containing OCs. So it is possible that the progestin that you use with the oral contraceptive may be the key to whether an OC will be effective in preventing, minimizing some of the late-term complications of polycystic ovary syndrome. Because not all progestins are created equal. Some are good, some are bad. Most of those with glucocorticoid activity are not friendly to the cardiovascular system. And examples of those that are not friendly to the cardiovascular system because of their glucocorticoid activity are ciprofloxacin acetate and MPK. So when you choose the contraceptive that you're going to use to treat some of the early symptoms of polycystic ovary syndrome like hirsutism, regulation of menstruation, etc., maybe you have to choose the right type of progestin. Right. I will end up my presentation by re-echoing what I mentioned earlier, but this time I'm not going to say it myself. I'm going to quote Professor John Lessler, who said that physicians, maybe I should change this to gynecologists, who see women with PCOS, because you're all gynecologists here, and do not assume the responsibility of comprehensively evaluating these patients, do their patients a disservice and provide inadequate care. And the reason, of course, is because these patients are liable to develop complications, cardiovascular, metabolic, etc., that may be of more worrisome consequences than the initial presenting symptomatology of acne, hirsutism, menstrual problems, and infertility. So thank you very much for suffering me again for about 8 months.